Hi everybody, my name is Harmeet Bains and I'm a Master of Nursing student at Athabasca University. And today I'll be discussing on the topic of my debate that all publicly funded palliative or hospice settings be required to provide medical assistance with dying, or otherwise known as MAiD, and I will be taking the opposition stance on this debate. Next, I'd like to do a little overview of the key terms that I'll be using within my debate, followed by the arguments that we use from an opposition stance in regards to this debate. So to start off with, let's define what MAiD is. MAiD stands for Medical Assistance in Dying. In June 2016, the Parliament of Canada passed federal legislation that allows eligible adults in Canada to request medical assistance in dying. The criteria to meet for MAiD is that two independent healthcare professionals, a medical doctor or nurse practitioner, must evaluate an individual to determine whether they qualify for MAiD. The additional criteria for MAiD, according to the Department of Justice of Canada, as of March 17, 2021, persons who wish to receive MAiD must meet the following eligibility criteria: be 18 years of age or older and have a decision-making capacity, be eligible for publicly funded healthcare services, make a voluntary request that is not the result of external pressure, give informed consent and receive MAiD, meaning that the person consented to receive MAiD after they have received all information needed to make this decision, have a serious and incurable illness, disease, or disability, excluding a mental illness until March 17, 2024, be in an advanced state of irreversible decline in capability, have enduring and intolerable physical or psychological suffering that cannot be alleviated under conditions that person considers acceptable. Publicly funded healthcare is financed with general revenue raised through federal, provincial, and territorial taxes, such as personal and corporate taxes. Canada has a decentralized, universal, publicly funded health system called Canadian Medicare. Healthcare is funded and administered primarily by the country's 13 provinces and territories, and each has its own insurance plan, and each receives cash assistance from the federal government on a per capita basis. Benefits and delivery approaches vary. All citizens and permanent residents, however, receive medically necessary hospital and physician services free at the point of use. Hospice and palliative care are about providing comfort and alleviating suffering without hastening death and to improve the quality of life for those living with life-altering or limiting illness. The World Health Organization defines palliative care as an approach that improves the quality of life for our patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering. Introducing MAiD into palliative care settings creates an inherent conflict with this philosophy, as it involves intentionally ending a patient's life, which contradicts the goal of maximizing comfort and quality of life until natural death occurs. Benefits of hospice care approach are pain and symptom management, assist to make important decisions, social, psychological, emotional, and spiritual support, and supporting the patient and the caregiver throughout the illness. My stance on this debate is that all publicly funded palliative care or hospice settings should not be required to provide medical assistance in dying. Mandating the use of medical assistance in dying in all publicly funded palliative or hospice care settings remains a debatable issue that raises ethical, medical, and practical concerns, with critics arguing that integrating MAiD into these care environments conflicts with the fundamental principles and presents numerous ethical, practical, and societal challenges. The goal is to provide comprehensive end-of-life care options. However, mandating every publicly funded institution to offer MAiD can undermine the principles of palliative care, compromise the integrity of healthcare providers, and disregard the diversity of patient and provider beliefs. Hospitals and health authorities have obligations to prevent harm to patients, promote patient health, and respect patient autonomy. Institution-conscious objection refers to the refusal of healthcare institutions to provide medical services that violate the institution's ethical standards or mission. The right of healthcare institutions to object conscientiously is protected in law in many authorities, in addition to being sanctioned by medical associations. Several theorists have argued that the institutions do not have a conscience and therefore need not be afforded conscience protections. Critics of institution conscience objection, also known as ICO, observe that institutions are fundamentally different to individual human persons, as a hospital is not a person but a physical structure within which providers give medical care. While institutions themselves do not have a conscience, they are composed of individuals who do. The policies and actions of an institution are influenced by the consciences of its members, particularly those in leadership roles. My next argument against this debate is that many healthcare providers who work in palliative and hospice care choose this field because it aligns with their personal and professional values of providing compassionate end-of-life care. Being required to participate in MAiD can lead to significant moral distress among these providers, as it conflicts with their ethical beliefs and commitment to non-maleficence. The moral distress can contribute to burnout, job dissatisfaction, and potential loss of skilled professionals from the field of palliative care. A doctor's right to act on their conscience should not be subordinated in favor of a dominant conception of morality or professional practice. As discussed by Carpenter and Vivas, conscientious objections to MAiD are grounded in arguments about the value of principles in medicine that include helping the sick, doing no harm, and respecting the traditional Hippocratic principles, pledges to neither suggest nor give a deadly drug to anybody who makes a request. It should be noted that a provider who exercises their conscious rights can violate the harm principle and unfairly harm dying patients by refusing them access to an essential and medically indicated service. To overcome this hurdle, systems should be in place to provide patients with the resources and information from a database of healthcare providers that are participants and willing to provide patients with MAiD. The following are quotes provided by Dr. Lee on the impact it had on her about administering MAiD for a client. The first quote is quoted as, "I gave MAiD against my clinical judgment because I will always do what's in the best interest of a patient if they have made a clear and reasoned decision." Dr. Lee states, however, she described feeling stuck because, unlike other countries, Canada doesn't require patients to try alternatives to MAiD, only to consider them seriously. Moreover, Dr. Lee said the law doesn't require clinicians to meaningfully discuss a patient's desire for death or the societal factors that may contribute to their request. Practice guidelines and training can emphasize the importance of these discussions, but as they're enshrined in law, they're ultimately optional. The main ethical issue is how can the rights of patients to access MAiD be balanced with the healthcare provider's right to exercise conscience-based objections to participate in the process of MAiD. Publicly funded religiously affiliated healthcare providers in countries such as Australia, the US, and Canada refuse to provide MAiD and other procedures that are legal and sanctioned by relevant professional associations due to their faith-based policies. These institutions are open about their mission and identity, which the government chooses to fund, and are aware of the services they will not provide. Being aware of this knowledge, it is difficult to support the argument that all publicly funded palliative care or hospice settings be required to provide MAiD. Another ethical argument against providing MAiD in palliative or hospice care is the principle of non-maleficence, which obligates healthcare providers to do no harm. Palliative care aims to alleviate suffering without hastening death, focusing on providing comfort and maintaining the best possible quality of life for patients with serious illnesses. Integrating MAiD into palliative care settings can be seen as conflicting with the principle of non-maleficence, as it involves intentionally ending a patient's life. This contradiction can undermine the ethical foundations of palliative care, which prioritizes life-affirming approaches even in the face of terminal illnesses. In conclusion, the institutional objection and opposition to requiring all publicly funded palliative care or hospice settings to provide MAiD are rooted in ethical, practical, and organizational concerns. These objections emphasize the need for respect for diverse values and approaches within healthcare and the potential negative impact on healthcare professionals. Policymakers and government should consider these factors and strive for a balanced approach that respects institutional integrity while addressing the needs and rights of patients seeking MAiD, as well as those who will be assisting in the process.